This is a 2.2 phaco on a complicated cataract in a case of Ward Koyanagi Harada syndrome or the VKH syndrome in a young girl. Now she, after controlling her almost for 2 years with a combination of both steroids and other immunosuppressants, she developed a complicated cataract, partly due to the uveitis, partly due to the steroids. Anyway, we had to take her up for surgery for visual rehabilitation. And this is how it went. So initially, I'm putting in my 2.2 millimeter keratome incision. The pupil is not very well dilated. I hope it will dilate with some intraocular adrenaline. This is a very soft cataract, and soft cataracts are really can cause a lot of hardship if the pupil is small. I'm putting in some intraocular adrenaline, and voila, the pupil dilates very well. So that's settled. So then after my incision, I have put in 2 side port incisions as well. This is a posterior subcapsular cataract, a complicated cataract. So I will stain the anterior capsule with trypan blue under air, expel both the air as well as the trypan blue with 2% HPMC. After putting some HPMC over the cornea, I take my bent 26 gauge needle and I am making a capsular excess large enough to, I would like to prolapse this nucleus out. This is very difficult to phaco in the bag. Not difficult, but it can be a pain if you form a bowl. And probably younger cataracts may be a better idea to go with the capsule forceps, but anyway, I seem to be managing, and that's done. And then start hydrodissecting, and look, it is just hydrodelineating almost. Go in multiple areas, and I can see the nucleus actually prolapsing. There you can see it. So it's very soft. Just put in some, she's young, so I put in some chondroitin sulfate as well, and then this whole thing is done just with purely vacuum. It's about 400 vacuum and 40 ml flow rate. You can go. I'm just trying to bring everything out with my phaco probe itself, and all with vacuum. There is no phaco power being used at all. And that is why you can see it's taking time. Actually helping it with my chopper, literally pushing it into the port. It's because I didn't want to use any vacuum in this case. That's done. Once that's over, I go ahead and aspirate all the remaining cortex from the fornices with my bimanual. You can see a slight reverse pupillary block going on there. I quickly equalize the pressures in both the chambers. I switch hands to take the cortex from the other side. I don't want a rupture in this case. In fact, I don't want a rupture in any case. Just cleaning up those little bits on the posterior capsule. It looks to be pretty clear. Then put in some HPMC, increase my incision to 2.8, and I am putting a yellow tinted lens in this case, a hydrophobic lens. It's an acrysoft lens. The leading haptic has gone into the bag. It's time to put the trailing haptic as well into the bag, and I seem to be having a bit of a problem, but I can just tuck it in. Yeah, that's done. Then go in with my bimanual to remove all the whatever debris and the HPMC and any cortical bits that may come. In this case, I would give a subconjunctival of DEXA. Maybe a good idea to put some triamcinolone in the chamber. I haven't done it in this case. Hydrate the wounds and conclude my session. Thank you very much for watching.